For this manuscript, we looked into the PD-L1 treatment in localized bladder cancer. And patients that have high-risk non-muscle invasive bladder cancer and have recurring disease and are classified as BCG unresponsive nowadays could be treated, especially in the United States, with something which is called PD-1 immunotherapy or PD-L1 immunotherapy. And this is actually a checkpoint inhibitor. And these kind of immune therapy, new novel drugs are very important and highly I'm highly enthusiastic about these kind of new drugs. However, the problem with it is that only 20 to 30% of the patients actually respond to this new treatment. So, and this actually also accounts for patients with localized muscle invasive bladder cancer. Nowadays, these patients are treated with neoadjuvant chemotherapy and then a radical cystectomy or radiotherapy in combination with chemotherapy. And these patients have like a 50 to 60% risk of death within 5 years. So also these patients are being, there's being explorations to treat these patients with PD-L1 immunotherapy. Now, both patient groups have a 20 to 30% risk of treatment success, which is very low. So we're trying to find out means to improve the actual response rate. And there are several approaches to do that. The first approach could be to treat patients with an additional PARP inhibitor. Because if we treat patients with PARP inhibitors, these are directed against the BRCA mutation, and these could increase the mutational load of the tumor and possibly also the susceptance to immunotherapy. A second approach would be by combining it with chemotherapy. I think that's a very important option. We noted that if you treat patients with chemotherapy, there is an increase in immune cells infiltrating the tumor. And if you then add immunotherapy, which is also further enhancing this the immunogenic tumor, the microenvironment, you could increase or actually boost the anti-tumor response. And then there's, well, several other options that we discussed. For instance, many patients that are non-responsive to PD-L1 immunotherapy seem to have an upregulation of TGF-beta. So nowadays there's also anti-TGF-beta drugs on the market, and it will be very interesting to see how these drugs, PD-L1 and TGF-beta, will go together, and maybe together the response rate will also increase. So that's basically, in a nutshell, 3 ways of how I think immunotherapy could be improved.